It is 7 o'clock, and welcome to Grand Rounds. Um, it became apparent in the course of our discussions that although the faculty have been engaged in a variety of forums in uh, discussions about topics related to diversity, equity, inclusion, and anti-racism, that the residents were less likely to have had the same level of courses and training and than the faculty. And so, as part of our plan to fix that, we decided that we are going to have some content within the Grand Rounds platform, as well as resident conference related to diversity, equity, inclusion, and racism topics. Very important. I don't need to uh, emphasize why this is important, that we all be engaged in an ongoing conversation about how we can do better. And it is our commitment in the Department of Surgery to do so. And this is part of that. So I am indebted to Dr. Faye Jones and Ms. Kiana Fields and Mr. Ryan Simpson, who help lead our DEI efforts on the health sciences campus and for the university at large. And they're going to talk to us today about an equitable workforce. So thanks. I don't know who's going first, but many thanks to all of you for being here on an icy, snowy, inhospitable morning. We appreciate the fact that we could have you all here with us.
Thank you for allowing us to come. Like I said, I'm here. This is Faye Jones. I am here today with Kiana Fields and Ryan Simpson, and it is actually much better to be here at my house doing this than going on the street. So thank you so much for that. All right. So Ryan, you want to put the slides back up?
Yep.
Our topic for today is pathways to an equitable workforce through a critical conscious framework. So that is something a little bit different, and we'll go into what that means very shortly. But a lot of the work that we've been doing on this is guided by Dr. Swanzia Rivers, who is in the College of Education. So we want to thank her for her efforts as well. Next slide. We have several ways of doing presentations, but we always start out with the rules of engagement. This is going to be an interactive session, so we really would like to generate discussion and thought during this. A lot of the material may be new to some, may not be new to others, but for some folks it may cause some very sensitive reactions, so kind of keep that in mind. I want you to first seek to understand, not to be understood. Sometimes we kind of get defensive on some of these topics, and we don't quite get to the point where we want to be. So ask clarification questions so that you understand where folks are coming from. Those questions be asked of each other as well. And typically, you're not the only one that may have some questions about what that means. Listen and respect other points of view. That is exceptionally important because we all have our own ideas of what that is, but let's listen to each other and be respectful of that opinion. Do your best to understand the pros and cons of every option, not just those you prefer. That is so important. Be objective and fair-mannered as you can be. Like I said, we all have our opinions and ideas of what is right and wrong, and a lot of times it lies somewhere in the middle. Okay. All right, we have several objectives, actually three. We want to explore how equity and anti-racism are vital to our workforce, initially by having a shared definition of the terms, which leads us to a discussion of how barriers related to equity impact their pathways in medical school, residency, fellowships, and faculty position. And finally, we hope to collectively challenge you to create potential solutions to organizational inequities that you have described during this discussion this morning. Next slide.
All right. Well, as Faye mentioned, this is going to be an interactive morning, hopefully. And I understand if you don't want to have your video on because, it is early. But I'm going to ask someone to read the definition we're using for equity out loud. We can have volunteers, or I can choose people, if I can read the names. How about Joshua? Could you read the definition of equity for us, please?
Equity, the guarantee of fair treatment, access, opportunity, and advancement of all, while at the same time striving to identify and eliminate barriers that have prevented the full participation of groups.
Thank you, Joshua. Appreciate it. Now, for Joshua and everyone else, what portions of this definition stand out to you as important or impactful? Are there phrases or components? You can put it in the chat too. Thank you, Kiana, for putting that there. I see you all are active in the chat. So yeah, what stands out to you? Definition of equity.
So I'll lead off, and try to break the ice here because our audience is not used to being so interactive on video conference. But hopefully, you're going to get them engaged here. But what strikes me is the second part, which is eliminating the barriers that have prevented full participation. It's not just about leveling the playing field. It's about eliminating the barriers that keep people from getting to the playing field.
Great, thank you. Anyone else?
I think one of the things that stands out to me is striving to identify implies that it's a work in progress, so it's not a definitive action, it's a process.
Yes, always work in process. No end point there. Thank you, appreciate it. All right, can I get another volunteer to read this definition or description of anti-racism?
Come on, all of you know how to read. I know it for sure.
When we choose to be anti-racist, we become actively conscious about race and racism and take actions to end racial inequities, individual, systemic, and structural, in our daily lives. Being anti-racist is believing that racism is everyone's problem, and we all have a role to play in stopping it.
All right. So similar question, what stands out to you in this description or definition? But again, you can put it in the chat if you don't want to unmute.
I think simply identifying yourself as someone who isn't racist isn't enough. You have to actively work to fix the problem.
Right. And I think we've seen examples on TV or maybe in just general parts of our life where someone says, "Oh, I'm not racist," as if that proves or is any sort of evidence that that we or others are taking actions to actually end racism. What about anybody else? Anything else stand out from this definition?
I think believing that it's everyone's problem and not just, I'm comfortable with it and then go about your way. It's kind of understanding that everybody else outside of you may be involved in this issue.
Yes, thank you so much. And I know certainly for offices like ours, that's super important. That it's the work of each of us, and that way it's not relying on just a few people It is, embedded through every little nook and cranny of our organizations, and our policies, practices, etc., to make sure this work is getting done and being integrated throughout. All right. Thank you. So, why is equity and anti-racism vital to our workforce? What does it do for our workforce? Why are we here today having this discussion? Improves, I think somebody said in the chat. Oops, it moved on me real quick. Improves patient outcomes, preserves innovation.
Yeah, I think one thing is that diversity is certainly shown to be beneficial, but also I think from our perspective, the patients that we're taking care of are diverse in nature, so we're able to meet that diversity.
And for you and anybody else, what does meeting that diversity actually do? What is the impact or the outcomes?
I think it's hitting them, meeting people at the level that they're on, in an environment that they're comfortable in, especially for vulnerable patients come in to us needing healthcare.
Yeah. So there is various amounts of mistrust of medicine in general and healthcare, and research shows heavily that that healthcare outcomes improve when the workforce is more diverse. When there's folks that you can identify with, whether it be on gender, race, religion, etc., various ways that we're diverse. Healthcare outcomes improve for patients, following health the recommendations of the healthcare providers, etc. All that improves when people can identify with someone that they're interacting with in our systems. And I think, to put it a little more harshly, people are dying disproportionately in our healthcare systems. Our health outcomes are not equitable. And our healthcare workforce is not representative of society that we're serving. So we need to do a lot of work to improve these systems. So that's why we're here. So just to show some of the information that we are not representative of our society, and we do this in each department that we talk with. So we try to find some data that relates to your field. But this is some comparison. The top graph is patient trend data, and it says this is patients by ethnicity from 2008 to 2018. And the bottom chart is surgeons by ethnicity from 2012 to 2018 in all 5 surgical specialties. As you can see, we do not reflect the patients that we're serving, and that has impacts on the health outcomes. We're also able to find the demographics of your department for the faculty. And again, we do this with each department we work with. We've been doing it with all the faculty in STEM fields. And we see similar trends. Unfortunately, that faculty aren't representative of the student population, or prepping to more reflect the students that will be coming in to our systems. So, do we just have a leaky pipeline to each of our phases, to medical school, to residency, to fellowship and faculty positions? That's what this article termed it as, but to me it's a very soft way of putting it, as if it's just accidental. But as we're going to explore today, there are some, our systems are designed this way, and there's things that we need to do, clear policy and structural changes that need to occur to end up with the goal that we want. But this article, called Shoring Up the Pipeline, which you can look up and we can provide a link to, talks about some of the ways they identified some issues. So in recruitment, it was suggesting increasing number of role models in leadership positions, decreasing barriers for applicants, decreasing bias in selection and interview processes. If you're going to address attrition and adding some systemic supports, suggest providing support for trainees' family needs, creating more equitable leave policies, certainly for residents, but across the board as well. Making our educational approaches more diverse to more diverse learning needs. And also addressing the cultural needs within the system itself. And then I know discussions at various departments, across School of Medicine, there's some work addressing promotion processes as well, but making those more transparent, especially in the tenure promotion process.
And I just want to bring up something from one of our fourth-year medical students, Tino, what he's doing that's addressing some of this leaky pipeline. He has a corporation that is looking at how the mentoring, how all the just different steps that's getting folks even into the healthcare system, into medicine. He is in his program, in his corporation, he's addressed many of those things. So if you ever have a chance to talk to him or look at his website, it is, I'm just going blank on the name of it.
Greater Influence is my understanding. Yeah.
If you look on his website, you can see how he's addressing it, and he has gotten engagement from across the nation related to the things that he's doing. So just an idea of how that can be stopped, that leaky pipeline.
And I think I've mentioned it in previous trainings, but I think it wouldn't hurt to bring it up again. Your data within your department about the demographics of who's applying to be there, who ends up being in across all the steps. If you disaggregate by at least race, ethnicity, and gender, you can see where the disparities are occurring, and which creates the disproportionality within you all's field, and then that gives you more focused, can give you more focused attention of where you can make some changes to address the inequities. So I think it's important to, what I kind of liked about this graph, it was from NIH article, it's talking about all the different system interventions that can occur to address health equity. But we're going to focus on this, today we're focusing on the health workforce and achieving equity, and we're getting largely at the composition, but also touching on some of these 6 other areas as well. And it says the goals are to advance the diverse composition of the health workforce, the social mission of health professions education. So again, what is our current mission and how can that be moved? Provider distribution according to population need. High need patients being served and targeted for service. Practice patterns that are oriented to addressing root causes of disparities, and safe and fair working conditions for all members of the healthcare workforce.
So Ryan has thrown a lot at you of looking at outcomes. We know that our workforce is not representative of the populations that we see. We know that there are disparate outcomes that are happening. And so what does this all mean, and what is a framework that you all can use in order to get past just the identifying, but really going through the process of identifying and really delving deeper into changing and reimagining our systems, because we know that our educational process is not equitable. The outcomes show that. One of the things that, as we were preparing for this presentation and looking at critical consciousness, a quote that really stands out to me is by sociologist Pierre Bourdieu. And in his outline of theory of practice, he highlighted this phenomenon that in a culture, things go without saying because it came without saying. Meaning our ideologies, our systems, our structures are often our norm without ever really legitimately being examined, analyzed, or subjected to critical discourse. If we think about the pipeline, when have we ever really questioned what is the point of the pipeline? What does the pipeline, who is impacted by the pipeline? Who designed the pipeline, and who is the pipeline designed for, and how can we reimagine a new pathway? And that's really where critical consciousness comes in. It gives us the opportunity to build capacity to be able to question and grapple with our systems and structures, and be able to delve deep enough to consider what it could be, and actually believe that we can change our systems in a way that centers equity and our shared humanity. So I'm sure you're wondering, what is critical consciousness? And in its simplest form, critical consciousness is simply a reflection and action upon the world around us. It was created by Brazilian educator Paulo Freire, who advanced this educational pedagogy to liberate the masses. So one of the things that is important from Freire's framework is that we all live in interdependent systems. And so it's important for us to first identify, critique, and challenge through actions the social forces and inequities that happen and that we often perpetuate, oftentimes unknowing, because of the context in which we find ourselves in. Next slide, please. So what does critical consciousness look like in action? So it's not enough just for us to think about inequities and health disparities. If that was the case, then we understand that health disparities exist, but not a lot of movement in terms of really impacting our society as a collective has happened. We do our best on an individual level, but as a collective, we know that for decades we've been struggling with some key disparities. And so what critical consciousness as a cycle looks like is first looking at bringing awareness to our systems, to inequities. And this often happens on two fronts. First, we must recognize our role, the role of our departments, institutions, and systems. What's happening within our systems, within our departments that are producing inequities and disparate outcomes. And then we also have to look at what are we bringing and recognize our own individual roles into perpetuating these systems, and look at how our values and identities that we bring into our spheres of influence are also playing into the perpetuation or sometimes the disruption of the systems. But we have to bring things into the awareness instead of just looking at it as our norm or just the status quo. Once it has been brought to our awareness, what Freire recommends is that we bring that to a critical reflection and analysis. This is where we start to ask questions. This is where we start to really probe and ask the why. Why are things the way that they are? You begin to challenge and say, could there be a new way of doing things? So, another thing is, what impact is this going to have on the department building culture, and then where did these policies, practices, and procedures? So it's really delving deeper into why did we inherit these things? Why are things the way that they are, instead of just accepting them as our norm? One critical piece to all of this is power and agency. When we think of power, we often have hit or miss experiences with it. But we also should understand that power is neither good or bad. Although we are conditioned to experience power in often negative ways, we live in hierarchies and often feel disempowered in those hierarchies. And so, what critical consciousness really challenges us to do is to identify our own power and also work together to create collective power in order to dismantle, our hierarchies, dismantle those power imbalances that exist that disrupt the ability to change the system more toward an equitable practice. And then finally, it is not enough just to know all of these things, to think about it, to bring it into awareness, but action must be taken. There is an activation piece that has to happen in the process in order to really start to be intentional in dismantling our systems that breed and live in inequities. Next slide, Ryan.
So, the department has many, many things to be very proud of. You've been first on such a variety of initiatives. And looking at your website, looking at a statement that Dr. McMaster's put in there is excellence is not an accident. Excellence is most often achieved when it's expected. Mediocrity can occur anywhere. Excellence is demanded here. So excellence just doesn't happen. Now, Kiana was talking about those 4 stages: awareness, critical reflection, empowerment, leading to action. And I think about a lot of you have been practicing that philosophy for a long, long, long time. That you've challenged policies, that you've challenged practices, that you saw as unjust. But I want you to think back and tell me talk about a time when you felt a call to action. What motivated you to act, and then what did you do? So lots of us can tell lots of stories like that, but I would like for a couple of you to tell me what caused you to act when you felt something needed to be done.
Well, it's a shy group of surgeons, Dr. Jones.
I see.
You can see that. I don't want to be the one who does all the talking, but maybe I can break the ice again. If people pay attention to what I've said, done, and written, you can look at our department and fairly judge our department as not being diverse enough, and that we have a lot of work to do. And my commitment is that we are 100% committed to having a diverse and inclusive Department of Surgery where everyone is welcome, and where we take actions to fix that. And one of the things that we have done in response to that is while our faculty it may not be as diverse as it could be, we've made some strides in at least increasing our diversity within the residency program, and that's been intentional and purposeful, because we've done things like some of the people who are involved here, Dr. Adamson, I don't know if Dr. Jones is on the line, Cindy Downer. We created a gender equity task force. We created a diversity, equity, inclusion committee, and they're involved in every discussion and every decision about hiring, about recruitment, about residency and fellowship and faculty recruitments, and they have a review and take part in all of those discussions, so that we can make sure that everyone is keeping in the front of their mind the importance of diversity and why it makes us better, so that we can have some tangible results in terms of our department, our trainees, and our faculty. So we're not where we want to be, but I think that was something that certainly motivated me to try and do something about where we are by getting others engaged. And part of this Grand Rounds is motivating other people to be thinking and about ways that we can do better and taking actions to do so.
Thank you very much. That shows that full circle, and it's a continuous circle. It doesn't just stop once you get to the end with action. It's a continuous, continue to raise awareness, that critical thinking, that empowerment, and you're giving other folks the power to make these changes and continuing that cycle over and over again. Because we'll never get to the end of this cycle. Anyone else want to share?
One thing that we were approached a couple years ago by the leadership of the student SNMA group, asking for mentorship. And so we've worked with them to develop a mentorship program where, we match up interested members of the SMA with surgeons who are sort of interested in being a mentor. But so I think it was really motivating to see students approach a group of doctors who really aren't perceived to be super approachable from the outside. Although internally I disagree, but I think from the outside we can be fairly intimidating. But they approached us with kind of a well-formed plan about what they kind of wanted and how we could help them, reach that. And I think that's important to sort of improve that pipeline, because you need more people into the pipeline to make sure the endpoints are improved. But I mean, I think that what really was motivating was seeing students who were so motivated to not only improve their potential, because they weren't asking for themselves, but for their their cohort and their colleagues. And so I think that was all really important. And I think that in creating a program where we have kind of this one-to-one mentorship really helped out, or is helping out. It's an ongoing work in progress for sure.
Yeah, that one I've heard a lot about and been very impressed. Would love for all departments to be able to do something like this. The students sing high praises of that program. So that is an excellent example. So thank you very much. Next slide.
If I can add one tiny point that part of why we're and yes, thank you all for giving examples. Is to tap into changes that you've made, but also in your department, but just when in other parts of your life too. Like, what deep down was the value that pushed for change? It could have, maybe it could have been an external force that helped get things going, but ultimately you decided to get on board with it, to make steps, to change the norm. And so that's what we're asking as part of this critical consciousness, reflection, and awareness, is like to tap into like, and in the past, what has really helped you to like, okay, enough of this, we need to change this thing, and to revisit that as we're talking about changes to make within your department.
So, part of this, the importance of this Grand Rounds is that this is a conversation that we all have to be engaged in, and it's an ongoing conversation and discussion, and sometimes is uncomfortable to talk about. But to answer your question, Ryan, George Floyd, Breonna Taylor. What made people stand up and say no more? I think, and many other examples. Why now have people become more engaged? It's pretty clear to me that there's been a new level of awareness brought on by many instances of problems related to racism and discrimination, and especially in the area of social justice, that people just have said no more, including us. So many of us. So
yeah,
interesting.
Thank you.
That saying says once you've seen something, you cannot unsee it. So that's what's kind of going on in so many people's minds. They've seen it. It was been there all along, but now you see it and you cannot unsee it, and you feel that urge to do something.
And it's also important to continue the momentum even when things start to wind down, because sometimes we see things and we get this burst of wind, but one thing that is so important is that movements are something that often take a long time. And so you have to be in it for the long haul. And it's also important to recognize that there is no such thing as a perfect solution for any of this. I think many folks come in to, especially to our office, and say, what is this prescribed action that we can take? And there is no such thing as a perfect prescription, right? There has to be continually examination of key points within the organization, within the system. So to get us to start thinking through common decision points, common areas where, trends are popping up, it's important for us to talk through it and practice critical consciousness. So I know that if folks can hop in the chat, I want us to start thinking about, Dr. McMasters, you've talked about the changes in the residency, the demographics within the residency program. So this is a great way to examine what you all have done there, and also looking at faculty searches. So some of the questions that I want us to think about for a little bit is, what are the critical questions that you or we as a group could be asking ourselves in the areas of looking at residency and faculty selection? What does that process look like? What do you all look for? And if you've never participated in a residency or faculty search, think through your time in medical school or any type of search that you've participated on a longer journey as a surgeon. So what are those critical questions we could be asking ourselves? Let's take probably about a minute and then throw some questions in the chat. Or thoughts. The doctor, knowing that since the system is inherently inequitable, how do we make sure we don't discount applicants? Yes, that is a great one, Dr. Farmer. A couple of more. Hit me in the chat box. Let's take until 7:39. And if you feel bold and froggy, also jump on and talk to us. So another question that we can think about is, how can critical consciousness be used as a framework to develop equitable policies? What is it? How can critical consciousness show up in your day-to-day?
There's some comments.
Thank you all. So I see our surgery program prides itself on creating an environment that is considered to be a family. How do we ensure that this is felt by the entire group? So that is a good question of, what does culture look like? What does family mean to the department? And does that definition of family, is it encompassing of all identities, groups, and ideologies? How can we make all applicants from different backgrounds feel more welcomed? Absolutely. We could delve deeper and say, what does welcoming look like? What does belonging look like? I think that often as departments, we let our communities that we serve come to us? What if we flip that and say, how can we go to our communities that we serve or communities that may be missing, and how can we incorporate their needs into how we are crafting our systems and crafting our policies and procedures? How can we make applicants feel more welcome? If we are not a policymaker, what individual action you can take? Absolutely. Individual action helps build the collective. Our systems are not upheld by just one person, but a collective of individuals. And so that is a great one of how do we look at our individual power and sphere of influence, and how can we start to move together to craft the department or organization that we're hoping to obtain. And so, Ryan, I'm going to pass it over to you.
So that was setting up perfectly for this question, and this is really aimed at the climate of surgery as a field, but also within your department. What could be done differently to make it more welcoming? So who currently feels welcomed? Who may not feel welcomed, and what would be some contributing factors to that are changeable? Do you gather data or information intentionally that gets to some of these topics?
So maybe Dr. Benz, you can, if you're, or Miller, can talk about the second trial, at least that addresses some areas of the climate within surgery training.
Sorry, Dr. McMaster, sorry, we've been having trouble getting some of the mics to work. I think one of the things that our department has already done that has helped a lot with inclusion and kind of getting feedback is Dr. Adamson had instituted the resident advocacy committee, and then Dr. Benz had also started, I believe it was my intern year, maybe the year before, meeting with the residents in small groups twice a year to get feedback about what's working, what's not working. And in a lot of those meetings, we have had conversations about how to better diversity and how the makeup of both our residents and our faculty are improving, things we can improve. So I think we are taking steps to sort of address that, but I'd be curious to hear if maybe people had additional ideas for things we can do as a department.
So Dr. McMaster has mentioned the second trial, and this is a national trial going on in surgery. It's called the second trial. It's an acronym. The first trial looked at work hour restrictions, and the second trial is a much more broader sort of look at wellness. And one of the things that it offers to programs who are enrolled, which most surgery programs are, and we are, they give you a survey every year, and this is survey questions that are attached to our yearly in-service exam. And so it gives you a pretty broad look at the opinions of surgery residents from across the country, and it's an anonymous survey, and it has a huge captive audience since it's part of the in-service. So it allows you to get this survey data that you would never ordinarily see. And then it shows you where your program ranks amongst your peers and other programs, and there's different categories and brackets as to how you're classified. But we found that very valuable in our department because it gives us sort of again, an anonymous look at how we're doing. And there's a lot of questions in that survey related to equity and inclusion and things like sexual harassment and other issues, and things that I think are sometimes difficult to figure out what's going on in your department without the anonymity of a survey like this. And so we found that information useful for the last several years to see kind of where we stand and help identify problems early on with issues like that.
That sounds like a fantastic resource. That's great. Yeah. So it's again, things like that, and having it sounds like you're already having some or starting to have some hard discussions about um, why people may feel like they belong or not, and what can be improved upon that. And these things can build upon each other. Like when some momentum gets going, you can hear more information. And I can see also, in the chat acknowledging that you're predominantly white males, and what that just that alone that could be intimidating. Or again, as we talked earlier, folks may not see themselves represented as much in the department. So being transparent about that, acknowledging that that's the current um, makeup, and acknowledging the impacts and making some changes because of that, not and being intentional, I think too is part of it. I know you all are probably not hurting for applicants, so it's not like you don't have people that are interested in your field, but it's again being intentional that it is a diverse a pool of applicants, and then people who end up being in your field as well to again improve outcomes, improve the environment, and health outcomes for patients. So I know we're getting short on time, so I want to get to kind of last big question. What is one thing that you can, based on our discussion today, that hopefully we stirred, that you want to make a change or to take something you're already doing one step further? And again, we're looking for urgency, something that you can do in a short term change. We would like some massive changes. We want more, residency options, but that would take some federal interventions. But what's something low-hanging fruit, perhaps, that you all can make a change to? Comes to mind.
Well, I'll throw one out, which is I pulled up this Greater Influence website, and it looks fantastic. I hadn't heard anything about it, so the one thing we certainly can do is figure out how to engage with the people involved in this mission to increase representation in medicine from underrepresented groups, and since this apparently is a program that's started by one of our medical students, we need to be, maybe others know more about it than I do, but I think this is something we could probably help with.
All right, thank you. We were blown away.
The amazing thing is he did this while he was in medical school. This has all been done in the last 4 years.
Yeah, he shared his work with us as well, and we were a little blown away. Like, oh, you were going to medical school as well while working on this.
He shared it with you after the fact, after it was all done. Didn't come ask for help or anything.
Now he's been part of our Health and Social Justice Scholars program. So
Okay.
He had a project to do, and then he also got his MBA. So between the two of these things together, this is what he came up with, and it's working, and it's just amazing.
How about one other person? What's one thing that even if it's tiny, that sparked a little bit of change in your mind? And it could just be the maybe not even change, but even like looking at something differently through the like critical reflection components.
Come on now, somebody's got to have some ideas.
Something that came up in our preparation for today as well was how often, I'm not trained in medicine at all, but how much of your training is and I've seen this in grand rounds and other units as well, is just the kind of, use this term, like the vomiting of information and then the absorption of that information, and just supposed to repeat it, right? And so how that system sometimes can, it doesn't allow for those critical reflection points in the topics as well. So I'm acknowledging and seeing that we might be a different format than what you all typically get in some of these, where it's a lot of just broad questions and asking to reflect on structural components. But a lot of our education is just, here's definitions, here's this, absorb it and go do it, without really an examination component of it as well. So that's something that came to mind when we were prepping. I was like, I wonder how much is that the norm in y'all's journey, and where could that's still, you all still have to absorb a lot of information, as do med students, in their journey. But where could some of those changes be made to allow for more critiques?
I'm going to give you an example of a kind of a low-hanging fruit that PEDS is doing, that we'll be doing. We are going to do a visiting internship type program that's targeting underrepresented in medicine students, medical students, to come in for their 4 weeks, and during that time exposing, hopefully give them a great experience, but if possible, that's what we were doing, the in-house interviews. There was a possibility of a meeting with multiple different folks in order to increase their likelihood of coming here. That program has been effective in many other institutions and has worked well, increasing the diversity of the residency program. So PEDS is going to be doing that starting in the fall as well. And it's not a very expensive program.
So tell me how, if you can give more details of how that works and how you identify people and make this whole thing work.
So it is an application process. People apply for it. You advertise it like you would for any other type of programming, and people apply for it. You have your criteria of priority populations, and you bring them in for the 4 weeks. Hopefully provide housing and a stipend as well. But then you make the rotation what you want. Some use it as mixture of clinical and research, some just all clinical, but while they're there, introduce them to other aspects of your program that might be more enticing for them.
And do you target this to historically Black medical schools, or are there other places you can help get this promoted?
Yeah, that is one area that you can target it to, but you can target it to, it doesn't have to be restricted to historically Black medical schools or colleges and institutions. But when you put out that application, you definitely want to target those areas as well, but you leave it open for every medical school that can be part of it. But
maybe SNMA is a partner that would help us to do this as well.
So there's lots of possibilities to bring in people that might be interested in it.
Yeah, I think that's fantastic.
What's one thing that would be great if multiple departments would plan on doing something like this. That way, it is not just bringing in 2 to 4 people, but you're bringing in a lot of people that can interact with each other, so they realize there's other folks that look like them here, or the potential. So you're building that bridge there.
Are you in charge of that program, or someone else in the pediatrics department?
So it is going to be through a residency program. So it's Sarah Molterer.
Okay.
She's been fighting for this for quite some time.
I think that sounds like a great idea. Maybe we can team up with pediatrics and take part in doing a similar thing. There's a comment from Dr. Brunderman here.
I think that as residents, our minds are racing from the second we step in the hospital, thinking that about everything we have to do for the day. Taking a single moment for those racing thoughts to be aware of our actions and interactions with those around us is low-hanging fruit that could potentially alter the perceptions of our coworkers and patients. Basically, just taking a single moment of awareness daily. You know, another possibility too is some places are actually looking at the policies related to discrimination and microaggressions within the hospital system, which is different than some of the policies that we typically have. But a lot of times, one of the things we hear is from not just our students, but our residents and our faculty is some of the microaggressions and discrimination and just racism that occurs within the system, and then there's no really formal way to address it because it doesn't, some folks think it doesn't rise up to that professional stuff that is in the hospital policy. This is something that's a little different. So we're working on policy change or additions in some cases within the health system would be very beneficial.
And I think in the next time we ask you or your colleagues to come help us, in terms of allyship, we all have a lot of coaching that we need to continue to have in helping to break down some of the microaggressions and racism that goes on every day, that may be very subtle in some cases, that some of us may not even recognize, that we need to do a better job of recognizing and standing up.
Well, we are out of time. We've enjoyed this journey with you all. We enjoyed creating this presentation for you all as well, and using it from some of our other presentations. But we're wondering if there's any remaining burning questions. You can put them in the chat. You can unmute, and also you can reach out to us after today if something comes up later.
Well, unless there are further questions, I want to thank all of our speakers for helping us to engage in this ongoing discussion about DEI and anti-racism topics. And as I said, this is a conversation that the first step is really just being able to have these kinds of conversations and getting more comfortable talking about these topics, and which is why these are more interactive sessions than perhaps our audience is used to, but we'll warm up to it as we get back together in person. I'm sure it'll make it a little bit easier. But we're all need to be thinking on a regular basis about how we can do better in all of these areas. So many thanks to all of you, and we'll move right on into our quality improvement conference, which you don't need to stay for that.
Thank you. Take care.
Thank you for y'all's time. All right.
Yep.
Bye-bye.